Okay, so we're back for our part 7 already, because I divided the video of the gastrointestinal system to two parts. So this is video number 7, or part number 7, which talks about the cancer of the thyroid. Welcome back. I hope that you're doing fine and well. This is a very much interesting topic from me. If you've learned something, that's good, because I'm relearning a lot of stuff as well as you guys. So let's go on with the discussion. Okay, so if you're going to follow the slides are, we're on slide 148 already. Okay, so if you're going with me, guys, just look at the slide. It's already uploaded in the Google Drive, so you could follow with me, or the Google Drive, in your Microsoft file folder dun sa classroom natin. Okay, so let's go on. So when we talk about thyroid cancer, this is the cancer, especially of your thyroid. This is the less prevalent form of cancer, so it's not that much. But usually, papillary adenocarcinoma, it's more consistent of 50% of the cases that are prevalent with cancer. Okay, so types would be your follicular adenocarcinoma, your medullary, your anaplastic, and your thyroid lymphoma. Okay, so for the risk factors, what do we have? Usually females, and here there are the risk factors. If ever you have external irradiation of the head, neck, or chest in infancy or childhood, you have most likely prone to having thyroid cancer. Okay? So, sir, medyo nakakalito naman yung sinasabi nyo. Grabe naman yung terms nyo na irradiation. Okay, so ano ibig sabihin yun? Okay, so let's define irradiation first. It's the process by which the object is exposed to radiation. Okay, so na-expose yung head mo sa radiation, yung neck mo or chest during infancy or childhood, prolonged exposure. Okay, so ano yung mga, sir, next question, tatanungin niyo naman din ako, sir, usually ano ba yung mga causes ng radiation? Okay, so radiations is usually caused, prolonged radiation, it's caused by infrared or visible lights. It may be caused from microwaves, from cellular phones, electromagnetic waves emitted by radio and TV receivers, and power supplies. And especially pag lagi ka nag-X-ray nung bata ka pa, okay? Or lagi ka na-expose dun sa mga CT scan na wala kang protection or lead protection. So those are probable causes of cancer of the thyroid. Okay, so for clinical manifestations, you would have your lesions. Okay, it may be single, hard, fixed upon palpation. Okay, so lesions na fixed, hard, and palpable. Usually, yan na lang yung ano nyan. Siyempre, at yun na yung ano mo nun, objective or assessment tool mo. And it may be associated with cervical lymphadenopathy. Okay? Okay, so what are the diagnostic methods? Okay, so here we have biopsy or aspiration of the thyroid gland. For example, sige, libre lait ulit. Okay, let me entertain you for a bit. This is the lady. This is the neck area of the lady. Yung ano niya is inflamed. Malaki yung kanyang thyroid dito. Ang gagawin nila is, sige, para maging ulit. Yeah, tingala yung babae. What they would be doing is they would be aspirating the thyroid gland with a needle, therefore the term needle biopsy or aspiration of the biopsy of the thyroid gland. Okay, the next one is function test through the blood, in-extract to sa blood. You have your FT3, FT4, and TSH. Okay, and then we have here next your ultrasound. Okay, so in ultrasound yung thyroid. You have your MRI, magnetic resonance imaging, CT scan, and thyroid scans. We have certain scans for that one. And then we have your radioactive iodine uptake studies. And last but not least is your thyroid suppression test. Okay, let's move on. So for the medical or surgical management, we have your total or near total thyroidectomy. This one would be the method of choice. So it would be the inflamed or the enlarged thyroid would be either partially removed or fully removed. Okay, then we have also the modified or extensive radical neck dissection. If ever lymph nodes are involved, pati yung mga lymph nodes tinatanggal. Okay, first we have our radioactive iodine. This one would be eradicating the residue of thyroid tissue. This one would be given or administered. We also have our hormonal therapy because thyroid is a gland which is responsible in excreting TSH to a euthyroid state. So usually we replace it with hormonal therapy. And you have your drug which is called thyroxine. It replaces for the thyroid hormone. So you would be taking it lifelong. Another choice would be radiation therapy and chemotherapy. Yan na naman yung mga RC natin. RC, lagi mo siya makikita sa cancer. Radiation and chemotherapy. Okay. So, this one is just passing. And usually, complications would just be the same. But here, diba? So, what are your potential problems? So, let's just go here. What are your potential problems with this one? So, you have pain in swallowing. If not, pain, swallowing difficulty. Okay, so meron ka rin na hormonal imbalance. If ever. Okay. So, yan, usually. So, pain, usually discomfort pag lumulunok. Kung meron kang lump sa neck area. Difficulty in swallowing. Therefore, it may indirectly lead to decrease in food intake kasi nahihirapan ka na nga lumunok. So, hindi ka kakain since nahihirapan ka every meal time. Therefore, decreasing your nutrient intake. And then, decreasing your nutrient intake and then decreasing your appetite, therefore decreasing nutrient absorption, therefore going to weakness, then anemia kasi malnutrition. Okay, so you know the drill. Okay, so usually yan yung mga ano natin. Okay, so additional here, I guess I didn't place the slides. So pre-operative, post-operative nursing managements would be for your pre-op. Usually, we go here to the management. So, nandiyan na naman yung anxiety natin. We have to deal with the patient's anxiety, coping, knowledge deficit, pain, and nutrition, a little bit of nutrition. Okay, so we know the drill, nursing management and responsibilities in dealing the problems with this one. So post-op, what would be the possible problems would be? So again, you have to do is pain, and then as well as coping, also knowledge deficit. you have to advise the patient on what to watch out. Okay, and then we have a special problem here. Just usually this is normal in the first few hours or days of the operation. It would be your communication impairment. Sir, bakit naman may communication impairment? So remember, your neck houses your voice box as well. If this one would be removed or altered, it would be affected for the meantime. And afterwards, there would be dressing, di ba? It would be packed by dressing, therefore, having the patient difficulty in speaking as well. So usually, expect your patient to have a hoarse voice. If the patient would be hoarse, hindi, or garalgal yung boses. Tagalogin ko na lang kasi baka sabihin nyo, ay, kabayang boses. Hindi yun. When I say hoarse voice, it means it's trembling and usually not that good, not that audible for the meantime, or parang paos or malat yung labas. Okay, so there would be communication impairments by that time. The patient may ask you, nurse, will be my voice get back? Or susulat niya kasi hindi nga siya makapagsalita. So the answer would be yes, it would be only temporary that your voice would be altered, but expect your voice to get back. Okay, so sir, paano pag hindi bumalik yung boses ng pasyente ko, naapektuhan? So that is one of your complications with the surgery. So you have to watch out for damage in the voice box after the surgery. Okay, so yun din, and nutrition as well. Okay, this is a short slide about thyroid kasi it's more of the same management. It only encompasses because you have your lifelong thyroxine din. Okay, let's move on to the cancer of the lungs. It's more specific, or your bronchogenic carcinoma. Okay, so let me just try to draw the lung. Okay, again, libre lait. Yan. Okay, so let's just divide it with imaginary. Okay, so this is your lungs. Okay, so for your bronchogenic carcinoma, example, this is the head of the patient. Sorry. Okay, bronchogenic carcinoma. So it's caused by cigarette smoking. It may be your primary or second-hand smoking. Okay, so why? Cigarette has chemicals, and diba, chemicals is one of the factors that causes someone chemical changes. So chemical changes that is contributing to for a person to have cancer. Therefore, prolonged use of cigarette smoking or second-hand smoking, yun nga, meron tayong saying or kasabihan na it's harder to be a second-hand smoke because at least the smoker has a filter in between him and the smoke or chemicals before entering the lungs. Kasi luging second-hand smoke because the fumes of the smoke itself, okay, plus the breath or the breath of the patient or the bacteria of the patient of the smoker's lungs would be passed to you. So doble yung doble yung bigay sa'yo, damage sa'yo. At least siya may filter. Yung second-hand smoker, wala. So, mas kawawa yung second-hand smoker. Okay, that's why you would be seeing familial history. So, take note of this, having in your interviews, the wife is not a smoker, never has been smoking, never has been using tobacco, but develops lung cancer. So how did it happen? So you have to consider she or the wife or the one with the cancer with the significant other having or exposed to smoking. So usually the husband or the partner is a smoker, therefore making her a second-hand smoker. So as a nurse, you have to watch out for that as well. Okay. You have here also occupational exposure for the radon gas. Okay. And then we have your environmental agents. You live near a factory, a whole factory, for a prolonged period of time. Okay, and then a chemical factory wherein the fumes sips out and you regularly inhale it. Gender is also a factor. It may be more on male or female depending on the lifestyle. Okay, kasi usually it's connected as well as to this. Genetic predisposition, underlying respiratory disease. If you already have COPD or TB, COPD is chronic obstructive pulmonary disease, and TB is your tuberculosis. If you have underlying causes of this, you may be predisposed of having cancer. So, sir, why? Okay, so remember, di ba? We have our chemical, our environmental factors, and we have here your viruses and bacteria. Di ba? Remember that one? Okay. So, infection, for example, you have TB of the lungs. Usually, your nodules would be, the bronchioles would have enlargement. Or COPD, there's thickening of the walls of your lung. And since it's a disease, your lungs would be pre-exposed to different types of what they call this different kinds of bacteria who are opportunistic, therefore always having infection in the lungs. Usually you're predisposed to having pneumonia. Okay, and recurrent bacterial infection could cause your lung to develop lung cancer. Okay, we go to the next. So we have their major classifications for lung cancer. We have your small cell lung cancer, which composes of 15 to 20%, usually originates from the major bronchi, and then you have your non-small cell lung cancer, which is 80% of the cases. Okay, so we have our subclassifications: the squamous cell carcinoma, which is 20 to 30, centrally located, it means within the midline. Large cell carcinoma, which is 50%, which grows fast. Okay, so let me just illustrate. Okay, here are your lungs. Mabilis on the lung. And this is your midline. Let me just make it distinct. Here's your midline. Here is your, ito yung center. Siyempre, pag midline, center na yan, diba? Center. And your extremities is peripheral. As well as here, periphery. Okay. So, yan. So, when we say squamous cells, usually they are centrally located. Squamous would be your, usually they build up here, near the center. That would be your squamous. Your large cell carcinoma, usually they develop, that represents the green. Okay, they start peripherally, so malalayo. Usually they start here. And they grow fast. Sila yung kumakalat. And then your we have here lastly the yellow, which represents your adenocarcinoma, which is 40% present as peripheral masses. So makikita nila bukol yan, mass na talaga siya, malalaki. Okay, tapos nagme-metastasize na din siya from bronchoalveolar carcinoma. So usually, let me just draw. Di ba yung bronchial natin, bronchus, end of yung mga lung. Usually ganyan yung niya. Usually cancer develops from this part. Okay, so nade-develop siya dyan sa bronchial area, and then it spreads and mutates and enlarges later on. Okay, so yun yung niyan. But usually these are metastasis. Okay, yung mga ganito nagme-metastasize lang siya, usually from there nagme-metastasize lang siya from regions and parts. Okay, let's go on to the clinical manifestations. Sa kasamaang palad, it's asymptomatic until late stage. So, late na siya na diagnose. Initially, parang ubo-ubo lang yan or parang pneumonia lang yan na paulit-ulit. Yun na rin pala yung cancer. And the next one is signs and symptoms depend on the location of the tumor, size and degree of obstruction. Yun nga, as we said in the first part of the videos, it depends upon the dimension or size and affectation on the system. Okay, so metastasis may be regional to distant in size. Okay, so what are the signs and symptoms that you would be expecting to be seen in the patient? Okay, first of all, you have your dry cough. Not just dry cough, it's chronic dry cough. So, hindi ka na nawawalan ng ubo or your patient is always having cough. Okay, that is the most common manifestation. Next one is dyspnea. This one is easily being tired or short of breath. Okay, kakaroon ka ng shortness of breath dahil sa easy activities. So usually this one is also in the early stage. Mabilis ka hapuin yan. And then recurring fever, para siyang TB. If you've studied the TB disease before, it's reoccurring. When you say reoccurring, paulit-ulit, repetitive is another term. Sa Tagalog is ulit-ulit lang siya. Cycle lang siya na bumabalik, nawawala, bumabalik, nawawala. Okay, another term that may be new to you is hemoptysis. Wow, ang ganda naman sir ng pangalan. Ano ba ibig sabihin yan? Pagsuka ng dugo, basically. So, if ever na, umubo yung patient, tapos medyo napasok ka. Sorry. If ever umubo yung patient, let me just clear on that. I'm thinking of another thing. Let me just clear. Hemoptysis is... Okay, so hemoptysis, okay, this is different. Let me just clarify. Hemoptysis versus hematemesis. Okay, so when you say hematemesis, this is your vomiting of blood. Let me just be clear. And then we say hemoptysis, this is spitting of blood. Okay, so from the lungs. Mas maganda ito Tagalogin eh. Ito, so pag sinabi natin when you say hematemesis or pag sinabi natin hematemesis, sumuka, may dugo na fresh. Hematemesis na yon. Hemoptysis, dumahak yung patient nyo, na ganun siya. Tapos, dumura. Pag dura niya, dugo talaga yung nakikita nyo. Pag nadura niya yung dugo, na alam nyo yung dinahak niya from the lungs, yon, that's what you call hemoptysis. Ito yung sinasabi natin dati, hoarseness, garalgal yung boses, the voice is a little bit choked and not that audible enough. Okay, that's hoarseness, garalgal or parang paos, dysphagia, hirap lumunok, okay, difficulty in swallowing, head and neck edema. So there is water or edema formulation within the head and neck. And then there is pleural effusion, pleural or pericardial effusion, evident if the tumor is spread in the adjacent structures. When they say pleural, it's more of your lungs. And when you say pericardial, it's within your heart. Okay, so when we say effusion, what does effusion mean? Okay, so effusion is basically defined as the abnormal collection of fluids in the hollow spaces or in between tissues of the body. So that's what you call your effusion. Okay, so for example, the tumor is spreading out in the there is much more pressure in the lung area, therefore there is pressure, there would be obstruction, therefore there would be fluid buildup. When there's fluid buildup, and there is a obstruction, the pressure would push the fluid inside the cells going to the spaces, which is the hollow spaces between the tissues of the body, wherein what are the near organs within the lungs. Okay, the pleural spaces or the pleural cavity outside the lung field, or pericardial outside the lungs. What's the proximic organ on the left side of the lungs? It's your heart. Therefore, going to the tissues outside the heart or within the heart area. Therefore, having it to have effusion. Okay, so yun yung mga adjunct structures. Okay, so we have here also weakness, anorexia, and weight loss. Okay, so chest has pleuritic or shoulder pain. For the late symptoms, it may have indication of metastasis. Yung parang ano na yung patient nyo, nag-heart attack, or parang masakit lagi yung dibdib. Usually, and shoulders, usually it might be caused by metastasis. But further correlation, or let me emphasize on this again. So it doesn't mean that the patient is experiencing chest pain and known to have history of cancer. Automatically it would be your pleuritic pain or chest pain for cancer. You have to work that out pa with cardiac markers, kasi baka mamaya cardiac in origin yon, iba rin naman ang management doon. So we have to correlate with the laboratories and other diagnostics to make sure. Okay, next one, for the assessment, we have your diagnostics or imaging. Paulit-ulit na yan: CT scan, chest x-ray, CT scan, bone scans. Sir, why do we have bone scans? Usually this one would be detection for metastasis. Okay, so we have abdominal scans for late in PET. So we have discussed in the previous videos. Liver ultrasound and MRI. We have also our sputum examination to determine if there is bleeding. And if you do culture and sensitivity, what we call CS, we identify the bacteria for antibiotic therapy later on. We have our fiberoptic bronchoscopy, transthoracic fine needle aspiration, endoscopy with esophageal ultrasound. Okay, we have your mediastinoscopy or medistinoscopy, tissue biopsy, pulmonary function test, ABG analysis, exercise testing, and tumor staging. Okay, so these are the assessment methods. This one is collaborative and would be ordered by the doctor. Okay, for the medical management, okay, again, it depends on the cell type, stage, treatment, and physiologic status. Surgery is also preferred, so later on we'll be discussing the surgery, but usually that would be removal of the tumor. If ever it spreads within the lungs, it would be local resection or lobectomy, or what part of the lobe is affected. Okay, we also have radiation therapy, chemotherapy, and combination of therapy. Also, we have gene therapy, or we would be determine yung TB gene aspect, especially if it's tuberculosis in origin. They would be reviewing the gene factor which is causing the probable growth. Okay, and then therapy with defined tumor antigens if with proper diagnostics are resolved. Okay, so we have managing the symptoms. Okay, side effect for specific treatment and strategies to manage them. For example, the patient is having difficulty of breathing. Therefore, the non-nursing or non-collaborative nursing management for that is resting and energy conservation. Okay, and then if ever there is sputum or it is infectious in nature due to COPD or tuberculosis, therefore we treat it with antibiotic therapy. So it depends on the specific treatment and strategies collaborated with the doctor. Next one would be our general relieving for problems in breathing. Therefore, number 1, maintain airway patency to give good oxygenation exchange. So we need the airway to be clear from any secretions. Number 2, remove it by deep breathing exercises, chest physiotherapy, and suctioning. If the patient is unable to expectorate completely, so we do suctioning. Administer of bronchodilators and medications as prescribed. To dilate the airway of the patient, we use bronchodilators to make the airway more spacious, or give it capacity for exchange of oxygen through the blood. Okay, this one would be supplemental oxygen as needed. So this one is not a protocol. It's only as needed, and be careful in giving oxygen to patients with COPD. So, sir, why? Okay, this is just an overview. You're just third years, but you would be discussing on this later on. When we say chronic obstructive pulmonary disease, there would be obstruction in your pulmonary area. Therefore, gas exchange won't be that good, or it's altered, hindi siya 100%. What happens if you supply oxygen? The blue would be your oxygen. What happens if you supply your patient with high doses of oxygen? Therefore, since may COPD na yung patient nyo, yung recoil ng lungs na hindi siya maganda. So therefore, madaming oxygen, ang byproduct ng oxygen in the lungs after ng exchange is, di ba? O2 papasok. Paglalabas na siya, what would happen? It would be carbon dioxide after na magamit. So used oxygen would be carbon dioxide, and it needs to be breath and to be exhaled. Okay? Pero since meron ka ng obstruction, what would happen? Okay? Since may obstruction ka na, there would be decrease in elimination of carbon dioxide in the body. So the more oxygen you give, the more carbon dioxide would be retained, na hindi basta-basta may ilalabas ng patient due to the obstruction in the lungs. That's why we don't give doses of oxygen, high doses of oxygen or prolonged oxygenation to people with COPD. We give them as needed, but not in a continuous or prolonged basis. Kasi yun nga, magkakaroon ka ng CO2 retention, and at the same time, you're at risk to have oxygen toxicity in high amounts of oxygen. So be careful in giving it. Okay, so we position the patient for a comfortable position. For example, your patient is having difficulty of breathing. Will you position your patient in a flat position? Yes or no? For those who have answered yes for a flat position, we do not give that because we promote airway, proper airway function. For good lung expansion, you place the patient in an upright position or sitting position, a Fowler's or semi-Fowler's position. Okay, so we also do pulmonary rehab as indicated. Okay, so reduce fatigue, assess for the level of fatigue, identify the possible treatable cause, energy conservation techniques, guided exercises as appropriated. We also refer it to the PT or occupational therapist. Okay, we do and provide psychological support. Okay, so plan with the family. Okay, so this one is guide them with their decision making. Make sure that they are informed with their decision making regarding the treatment options. For example, the patient is unconscious already. Yun nga, with the help of the healthcare team, help the patient plan for the possible outcomes for the patient. If the patient is awake and can manage and make decisions for his or herself, inform and involve the patient in decision making regarding the treatment options. Okay, so there would be methods to maintain the patient's quality of life. For example, removing a lung or a lobe would decrease the quality of life for a patient. So there would be other methods to do that. Either they opt for palliative care, do not resuscitate, or advanced directives. It's up to them. And then here, support end-of-life decisions. Yun nga, advanced cardiac life support. If ever they would be using that, or DNR, do not resuscitate status, do not intubate. If ever they don't want the patient, or they opt the patient not to undergo invasive procedures. So that would be the decisions to make. And then lastly, they would help identify resources for support, because having patients with lung problems would drain them financially and emotionally. So resources and support is gladly or really advised for the patient. Okay. Next one would be leukemia. So I'll be cutting this one for the part, if I'm not mistaken, part 9. Would be doing this in a separate video, so it won't be long. This one is a little bit of a long video. And thank you guys for making it through the end of this video. I hope that you will read more on this very interesting topic, which is cellular aberration. So I hope that you've learned something today. I pray that you would have a great day, whatever time you're watching this video, and I would be seeing you in the next part. So bye bye.